Okay, so we just look at the 7 on the scan as well, and just how the anatomy is always a little bit different in the 7 than the 6s. So on the 7s, there's almost like one entrance from the mesiobuccal and the mesiolingual canal, and there's one circular entrance for the distal canal. And as we scroll down through the tooth, we can see that there's a very fine isthmus between the mesiobuccal and the mesiolingual canal. And that can be important because if that's left full of necrotic tissue, you need to generally use augmented irrigation techniques to be able to clean that area out. So again, the cone beam CT really helps us to realize that it's not just small round canals like on the plastic blocks where lots of the endodontic training is doing. It's more root canal systems rather than root canals. And on this helps me decide how I'm going to instrument the tooth and how I'm going to irrigate the tooth. So as I come right down, the smaller that the canals become, the thinner the actual isthmus is. And in this case, there's almost an isthmus the whole way down the tooth until the canals meet in the apical third. And that's really interesting because you've got multiple kind of options in terms of treatment of that. Some people like to put a very small little file and actually trying to instrument the isthmus. Other people will just prepare the 2 main canals and use augmented irrigation techniques to get it really clean. Also, you can see here in the distal canal, just where the mouse is, that there's lots of calcification in the distal root. And again, that's really good to know because if you're going to choose a stiff file, you're going to be more likely to be able to penetrate through the calcifications, whereas if you use a very soft, flexible file, often the tip is not going to be able to penetrate through that calcifications and you're going to have problems. So having the scan helps me choose the type of instrument that I'm going to use before I even get into the canal, and that's really, really valuable. And here in this case, we can see exactly where the canals exit. So in this case, there's like a sharp curvature in the apical last millimeter. And that's why the resolution is really important for endo, is that if you're struggling to get patency in a case, a lot of the kind of scanners where you have lower resolution, you can't see that kind of detail. Whereas when you can see this detail, which is done on a real patient, it's then that means you know that if I'm trying to get patency, you know exactly the direction where the root canal is leaving. So you can pre-curve your instruments and it saves so much more clinical time knowing that, rather than if you have an image where the apical resolution isn't good enough, then you're literally trying to get the instrument to feel where the exit of the canal is. So again, it's just knowledge is power is time. And it's like, for me in my practice, anything that saves me time, it's great for us as a practice, but it's great for the patients because patients don't want to have any extra long treatment planning time or treatment execution time.